Cast is now starting. All attendees are in listen-only mode.
Good afternoon. Thank you for joining the We Can Educational Series. Today, Jennifer Yates will discuss perinatal substance abuse. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. To ask a question, you can use the question pane on the control panel. Questions will be addressed at scheduled breaks. To obtain continuing education credits for today's session, you must track your attendance by texting today's code to the phone number on the screen. The code and phone number will be displayed at the end of today's session. After reporting your attendance, you should log on to your account at ocpe.mcw.edu and complete an evaluation within 10 days. To view step-by-step instructions on claiming continuing education credits and to see a list of future webinar topics, please visit wichildabusenetwork.org/webinar. Now we will proceed with today's presentation.
Hello, this is Jennifer Yates, and I'm a nurse practitioner with Children's Wisconsin. Thank you for joining us today. We're going to talk about substance abuse around pregnancy, the problems that result, the exacerbation from the opiate crisis, and some strategies to improve outcomes. Outcomes for infants, outcomes for families, and outcomes for our society. I have no relevant financial relationships to disclose. Remember, if you wish to receive continuing education, you must complete the evaluation. I hope you will find value in today's talk. The information being provided today is generalized, and it is advised that you consult with your individual legal counsel regarding practice in your agencies. I hope that today you will better understand the scope of the problem of perinatal substance abuse, be able to identify risks of perinatal substance abuse, including opiates, improve your ability to identify affected women and infants, and identify interventions to improve outcomes for women with addiction and their families. So I always talk about Martha when talking about this topic. I met Martha in 1995. I was working in Southern California as a public health nurse for a home visitation program with the goals of improving outcomes for pregnant women affected by substance abuse and or infected with HIV. Now, the early 90s was an exciting time to be involved in public health as AIDS clinical trial group 076 was using AZT during pregnancy, during labor and delivery, and decreased the risk of perinatal transmission from mother to baby from about 30% to less than 3%. This study had to actually be stopped so that all women in the study could be offered AZT. So the program again was to improve outcomes. Martha was referred to me by AIDS Services Foundation, and she was living under a bridge using heroin, and she was pregnant. She had cellulitis, and I walked under this bridge and met her, had a little Doppler in hand to help her listen to the heartbeat of her baby, and encouraged her to let me help her by helping her access prenatal care. This was her 5th pregnancy, and all 4 of her children went immediately into foster care, and she did not visit any of them. Martha had a history of sexual abuse prior to age 12. The outcome for Martha was that she agreed to go into some housing. She agreed to prenatal care. She took medications to prevent the transmission of HIV to her baby. She did get on methadone and continued to use heroin, but she delivered a full-time baby that was HIV negative. The highest incidence of illicit substances used during pregnancy is in the younger population who also have challenges with parenting due to their age. The 2016 National Survey on Drug Use and Health reported that amongst pregnant women, 9.5% consumed alcohol, 6.3% used illicit substances, and over 15% smoked cigarettes. You will hear more about this later in the presentation, but an infant born to a mother with a substance use disorder is at risk for withdrawal, commonly referred to as neonatal abstinence syndrome. Neonatal abstinence syndrome is a variable, complex, and incompletely understood spectrum of signs of neonatal neurobehavioral dysregulation. Although most commonly associated with opioid exposure, other substances have been associated with an abstinence syndrome, including nicotine. Additionally, other substances such as cigarettes, benzodiazepines, and selective serotonin reuptake inhibitors can potentiate the severity of opioid-induced neonatal abstinence syndrome. In the United States, the rising incidence of maternal use of opioid-containing pain relievers has contributed to an increased incidence of neonatal abstinence syndrome. This slide is a visual of the relationship between the increase in opioid use among mothers and the increase in the rate of neonatal abstinence syndrome. And this slide shows the increase in heroin deaths, deaths related to prescription opioids, and deaths related to all opioids between 2000 and 2016. The rate per 1,000 births of neonatal abstinence syndrome in Wisconsin by county is illustrated in this slide. Prenatal alcohol and drug exposure negatively affects growth and development of the fetus. Ongoing interventions are often needed to treat physical, neurodevelopmental, behavioral, academic, and socio-emotional problems for exposed infants. As maternal drug use increases, so do neonatal admissions and poor health outcomes in the first year of life. Substance users may not seek prenatal care because of fear, and unintended pregnancy is common in women with addiction issues. The societal impact of prenatal substance abuse is often maybe a factor in more than half of child welfare cases in which young children are removed from custody, and in approximately 25% of cases with substantiated maltreatment. Drug abuse can impair parents' ability to provide a safe environment for children, and the number of children removed from their home where drug abuse by the child's parent was a factor more than doubled from 2009 to 2016. While meeting the needs of fetuses and infants, it is important to remember that many of these women are yesterday's children and strive to provide trauma-informed care to the whole family. I suspect most of you have heard of the Adverse Childhood Experiences Study, which examines the relationship between self-reported adverse childhood experiences and future adverse health and psychological issues. ACEs include having substance abusing parents, incarcerated parents, and childhood maltreatment. And the study shows that ACEs increase adult risk of alcoholism, drug abuse, depression, suicide attempts, smoking, sexual risk behavior, and poor health outcomes. In my years providing case management to women who were using substances during their pregnancy, most of them had a history of sexual abuse. Substance use in pregnancy can be harmful to the health of the mother and the fetus. It's important to understand addiction, which is a brain disease with compulsive substance use despite harmful consequences. There are adverse consequences that extend to families and communities. And effective treatment is usually long-term, involves relapse. It may involve medication, psychosocial treatment, and family therapy. And I'm going to pause to see if there are any questions.
No questions.
Okay. So the official journal of the American Academy of Pediatrics published this report in 2013, reviewing available data on the short and long-term outcomes of infants exposed to these substances, which are the most common drugs involved in prenatal exposure. So there are direct and indirect effects of drug use during pregnancy. The direct effects are the effects on the fetus from the drug use itself. Early in pregnancy, this may cause physical defects. And after the major development, drug use later in pregnancy can lead to abnormal growth and changes in brain organization. Some of the indirect effects include vasoconstriction, which restricts fetal oxygen supply. Vasoconstriction is extremely detrimental to the growth and health of a developing fetus, as it may decrease oxygen and nutrition to the fetus. We are unsure the extent to which drugs cause harm versus the health risks related to maternal behaviors as well. Maternal behaviors, including poor nutrition, non-compliance with prenatal care, and exposure to infections and domestic violence. So the placenta, as you can see, this red area on the top of the uterus is very vascular. And vasoconstriction just means that this placenta, which is rich in blood supply, the vessels constrict and again decrease nutrients and oxygen being delivered to the fetus. It also increases the risk for abruptio placenta, which is tearing away of the placenta from the uterus, which can cause death of both the mother and fetus. The negative effects of nicotine during pregnancy are likely due to hypoxia, undernourishment of the fetus, and vasoconstrictor effects on the placenta and umbilical vessels. Prenatal exposure to alcohol is a leading cause of birth defects and developmental disabilities. Avoiding alcohol consumption during pregnancy is the main preventative cause of cognitive disability. Alcohol has the potential to cause harm to the fetus at all stages of gestation. Alcohol can cause developmental abnormalities in the fetus that are irreversible. Fetal alcohol spectrum disorder includes the range of effects that could occur in children exposed to alcohol prenatally and includes physical, mental, behavioral, and/or learning disabilities. Fetal alcohol syndrome is the most serious type of fetal alcohol spectrum disorder. You can see the abnormal faces, microcephaly, a small head, a smooth philtrum between the upper lip and the nose, lower set eyes, microganthia, which is a condition in which the lower jaw is undersized and may interfere with a child's feeding. And here is a list of the symptoms seen with fetal alcohol syndrome. Alcohol use in pregnancy, particularly binge drinking, is harmful and can lead to growth, academic, and behavioral problems in childhood and across the life course. And there is no known safe level of alcohol consumption during pregnancy. Marijuana has been linked to increases in hyperactivity, impulsivity, inattention, externalizing problems like aggression, and memory deficits. Marijuana use during pregnancy may alter brain neurotransmitters and brain biochemistry and cause abnormalities in an infant's neural behavior, and is associated with deficits in school achievement, problem solving, and attention. Cocaine is an addictive stimulant that crosses the placenta and blood-brain barrier. It is a potent vasoconstrictor that increases the risk of premature rupture of membranes and abruptio placenta. There was a high prevalence of prenatal crack cocaine use during the 80s and 90s. It can be snorted, smoked, or injected. Cocaine has a rapid onset, causing an increase in the release of dopamine, causing a rewarding high. Again, it is a potent vasoconstrictor, which can cause devastating effects on the mother and fetus. Methamphetamines is a powdery substance that can be eaten, snorted, smoked, or injected. There's limited data available, but it does cause vasoconstriction. A possible mechanism of action also includes an interaction and change in neurotransmitter systems in the developing fetal brain. Most studies do not control for other factors such as tobacco use, polydrug exposure, nutrition, and access to prenatal care. In the United States, heroin and methadone are the most common opioids used during pregnancy. According to the CDC, overdoses from heroin, prescription drugs, and opioid pain relievers surpassed car accidents as the leading cause of injury-related death in America in 2014. There's also an increase in the use of hydrocodone, which is Vicodin, and buprenorphine, which is Suboxone. Neonatal abstinence syndrome is the most significant effect of prenatal opiate exposure, and there are long-term effects on behavior. And there is not a consensus on the effects on cognition, language, and achievement. Heroin also rapidly passes through the placenta and accumulates in the amniotic fluid. It may be injected intravenously, snorted, smoked, or used as a suppository. Heroin is more accessible now, cheaper, and more pure than it was 20 years ago. Addiction to prescription opioids often precedes heroin use. Prescription opioid analgesics such as hydrocodone, oxycodone, codeine, morphine, and methadone have increasingly been implicated in drug overdose deaths over the last decade. Changes in pregnant women's daily heroin use can cause fetal abstinence syndrome, increasing the risk of premature delivery and death. Chronic untreated heroin use in pregnancy is associated with poor fetal growth, premature rupture of membranes, preterm birth, stillbirth, neonatal abstinence syndrome, and increased rates of infections such as HIV and hepatitis. So here is a nice chart showing the short and long-term effects of these substances. Note that prenatal substance abuse is universally affecting behavior. And I think it's important to remember that children with behavior problems are at higher risk for child maltreatment. So there is an opportunity to provide intervention to women with substance abuse disorders who have challenges with their parenting and children who may have their own challenges. And I'm going to pause for questions.
No questions.
Okay, the next thing I'm going to talk about is screening. So screening moms and screening infants for substance abuse. So one way to do screening is self-report. So asking women about their substance use history, which is inexpensive, but there may be issues with accurate history or recall or fear of telling the truth. Also, biological specimens. No biological specimen when obtained randomly identifies prenatal drug use with 100% accuracy. However, some common specimens include urine, which identifies recent use, hair, which can reflect drug use over a period of time, and meconium of infants, which can reflect exposure during the second and third trimester. Urine has been the most frequently tested specimen because of the ease of collection. Some issues with screening include, however, who do we screen? The mother, the infant, or both? Do we target high-risk women with a risk of bias, or do we implement a universal screening, which is costly? The American College of Obstetricians and Gynecologists recommends screening all pregnant women for alcohol and illicit drug use as part of routine obstetrical care. Screening should be repeated during pregnancy, and remembering that denial, fear, and guilt are barriers to self-report, and the use of a validated screening tool is recommended. CRAFT substance abuse screen for adolescents and young adults is available for use without restriction. And 2 or more positive responses to the following questions indicate the need for further assessment. A respectful approach is important, and there are many other screening tools that may be used. So these are some general possible indicators for substance abuse. As the data shows us, young women, especially adolescents, women who are not accessing prenatal care or have multiple missed appointments, and presentation to an emergency room, especially from burns, fights, or motor vehicle accidents. These are some psychosocial indicators: enrollment in drug treatment, history of a previously prenatal drug exposed infant, family history of addiction, history of abuse, and loss of custody of other children. These are some physical indicators. As we talked about, vasoconstriction increases the risk of premature labor and abruptial placenta. History of GI bleeds, ulcers, pancreatitis or hepatitis, cellulitis, skin abscesses, endocarditis, which is an infection of the heart that is frequently seen with IV drug use, poor dentition, suspicious trauma, and symptoms of withdrawal, to include dilation or constriction of pupils, tachycardia, sweating, and slurred speech. So according to Chapter 146, physicians may test an infant or expectant mother to determine if positive test for controlled substances if the physician determines serious risk for a positive result due to use while pregnant. And if the infant is positive, they must report to child welfare. If the mother is positive, they may report to child welfare. And while an infant can be tested without parental consent, the mother cannot be tested without parental consent. And once the child is born, if they test positive for drugs, it is up to Child Protective Services to determine the next steps and if court involvement is necessary. Developing a risk assessment and standard interventions may be helpful. Hospitals likely have their own policies on testing expectant mothers and babies and what items they look at before testing. The American College of Obstetricians and Gynecologists Committee opinion is that drug enforcement policies that deter women from seeking prenatal care are contrary to the welfare of the mother and fetus. Incarceration and the threat of incarceration have proved to be ineffective in reducing the incidence of alcohol or drug abuse. They further state that obstetrician gynecologists should be aware of the reporting requirements related to alcohol and drug abuse within their states and are encouraged to work with state legislators to retract legislation that punishes women for substance abuse during pregnancy. The ABSAC advisor in November of 2019 published a report on substance abuse in pregnancy, questioning whether or not this was a form of child abuse. 23 states consider substance abuse in pregnancy to be child abuse. Some argue that this approach deters women from seeking prenatal care, and others argue that CPS should consistently substantiate child maltreatment to ensure parents and children receive necessary treatment and services. These are some practical goals for interventions during pregnancy, and they include removing barriers to accessing prenatal care and drug treatment and mental health, helping these families with their basic needs, providing ongoing education on caring for infants, to include caring for infants who have been exposed to drugs in utero. Having a non-judgmental approach is trauma-informed, as many of these women have long histories of trauma. Home visitation programs have been shown to increase and improve pediatric healthcare visits compliance, compliance with immunizations, as well as decrease child maltreatment. Providing education to mothers on infant crying and assisting mothers in understanding and identifying infant cues is an important part of these visits. The importance of prenatal care cannot be underrepresented, as prenatal care improves the health of the substance abusing woman and unborn child, even if the mother continues to use. Identifying and treating infections such as HIV, hypertension, gestational diabetes, and preterm labor. And screening women for substance abuse can lead to interventions that encourage and educate women to help minimize poor birth outcomes. Treatment, okay, now I'm going to talk about, before I go into treatment of opioid use disorder during pregnancy, I don't have a slide here, but I just want to pause to see if there are any questions.
Yes, there are. So one is when using, and this was back when you were talking about testing, when using cord stat for an example, can that be dated regarding the use?
Cord blood would indicate recent use, just like blood would. The meconium would be, so it can't be dated like exact, but it would be more recent.
Okay.
Like blood or urine.
Great. And another question, so a hospital can test a child without parental consent?
Correct.
Okay, that's all.
Okay, so now I'm going to talk about the treatment of opioid use disorder during pregnancy, which is known as medication-assisted treatment. Medication-assisted treatment is the standard of care for people addicted to opioids and opioid use disorder during pregnancy. Medication-assisted treatment for opioid use disorder during pregnancy is usually with either buprenorphine, which is Subutex, or methadone, and results in improved maternal and neonatal outcomes. Medication-assisted treatment should be combined with therapy, treatment of comorbid conditions, case management, parenting support and education, and employment training. So methadone is a long-acting opioid agonist that binds and blocks opioid receptors, reducing the euphoric effects of subsequent opioid abuse. And when a woman is addicted to opioids, she spends a lot of her time searching for the drugs that she needs to avoid withdrawal. So one of the things that medication-assisted treatment does is keep this woman from having to hustle or seek drugs, use needles, have fluctuation in withdrawal that affects her infants, and instead focus on nutrition and accessing prenatal care. Suboxone is taken sublingually. Suboxone is a combination of Subutex and naloxone. So a patient must be abstinent from other opioids for at least 24 hours prior to using Suboxone to prevent withdrawal because of the naloxone. So the naloxone, or Narcan, is a narcotic antagonist that blocks the effect of narcotics and can cause severe narcotic withdrawal when injected. So that's how come we give Subutex. It doesn't have the Narcan in it to pregnant women because we don't want them to go into withdrawal. But Suboxone contains this Narcan so that it's not abused by injecting it. It has very poor absorption in the gut, so when taken sublingually, the way it's supposed to be, you won't go into this, this withdrawal. But if you inject it, then you could. But it's contraindicated to give the Suboxone during pregnancy. I also have a slide coming up from WAPC website that lists these educations and can be printed out for your reference. So again, medication-assisted treatment can stabilize patients who are spending most of their time trying to obtain heroin or prescription and is more effective for long-term success. Heroin-addicted women using medication-assisted treatment, including methadone and Subutex, have infants with higher birth weights and lower rates of intrauterine growth retardation. Addiction affects the health of the individual and the health of the public. IV drug use is a vector for the transmission of many serious infectious diseases, particularly HIV and hepatitis. However, neonatal abstinence syndrome is an expected consequence of medication treatment with methadone and Suboxone and can be treated. So hospitals should adopt policies to screen that comply with local laws and avoid discriminatory practices. Neonatal screening often involves urine screening, which, as we talked about, can tell us about recent exposure from substances, and meconium. The problem with the meconium is the testing results usually aren't available prior to hospital discharge, and the analysis of meconium may indicate drug use during the second and third trimester and not reflect periods of drug abstinence closer to delivery. So again, neonatal abstinence syndrome is commonly associated with opioid exposure, but other substances have been associated with neonatal abstinence syndrome also. It is not defined by the need for pharmacology. Another term is neonatal opioid withdrawal syndrome. Neonatal abstinence syndrome describes neonate at risk for polysubstances exposure, including opioids, and these terms are often used interchangeably. The American Academy of Pediatrics recommends the use of an objective abstinence scoring tool to measure the severity of neonatal abstinence syndrome. And the Finnegan neonatal abstinence scoring system is often used to measure the severity of neonatal abstinence syndrome and guide pharmacologic therapy. When despite supportive care, infants exhibit significant symptoms of withdrawal. Again, it's important to note that crying is a trigger for abusive head trauma, and these infants often cry a lot. It's important that parents understand crying and how to comfort and treat these infants. Breastfeeding can sometimes be encouraged in some opioid-dependent mothers if they are in drug treatment and not using illicit substances, but taking Subutex and or methadone. The American Academy of Pediatrics considers the use of illicit drugs, including marijuana, opioids, heroin, cocaine, and methamphetamines, a contraindication. Breastfeeding can be safe with medication-assisted treatment and reduces symptoms of neonatal abstinence syndrome. HIV also would be a contraindication to breastfeeding. So many of these newborns need special care and have prolonged hospital stays. Consider rooming with the mother and breastfeeding as appropriate. which can promote bonding, and nurses and other healthcare providers can support bonding by helping mothers understand what the infant is experiencing, how to intervene, and how to read infant cues. The use of medication as needed. Education that these symptoms may persist long after the medication is weaned. And again, home-based intervention and early intervention programs enhance child development. Evidence-based programs exist that have shown reductions in child maltreatment, such as home visits by nurses to mothers at high risk, and other parenting programs as well. So during the postpartum period, the mother who maybe was trying to protect her baby may no longer be worried about protecting the unborn child and relapse. This is a time when this mom may be experiencing other stressors and need additional support and safety planning. Some of the goals during the postpartum period are that the mother continue drug treatment and mental health, follow up with her medical care, discuss family planning, and the goal to reduce having more substance-exposed infants, having the mother understand neonatal abstinence syndrome, growth and development, infant nutrition, infant safety, and crying. Again, crying can be a trigger for infant abuse. Supporting bonding, discussing safety plans, and appropriate medical follow-up and developmental follow-up for the infant. Some of the challenges for new moms with substance use disorder is that neonatal abstinence syndromes often do continue, making these infants challenging to care for. Many of these women lack social support, they lack basic baby care items, stable housing, transportation, and other resources. Additionally, many of them have poor preparation for parenting and lack role models. So there's a high risk for relapse now that the baby's born. So thanks to Dr. Ann Budzak for sharing the next few slides. Dr. Budzak practiced at Gunderson House for 28 years, providing care to children with concerns for child maltreatment. And she developed a foster care assessment clinic as well as Gunder Kids. Gunder Kids is a model of care for infants born to parents with substance use disorder and continues to provide services in La Crosse, Wisconsin. So Gunder Kids is a program for infants and their parents with substance use disorder, and it's located in a general pediatric clinic. It's a means of support for families with these multiple challenges. There's an opportunity to provide continued care to infants with neonatal abstinence syndrome, and it's a way to provide education on parenting as well as child development. The program goals are to grow healthy babies, help moms and dads be successful parents, keep them together by creating a healthy environment, and prevent child abuse. The program structure is 17 clinic visits in the first year of life, which is more than double of what is usually recommended. Weekly visits for the first month, visits every other week until 4 months, and monthly visits until 6 months, and then visits every 6 weeks until 12 months, and then back to a routine schedule. So this is really supporting mom during that first year. The Gunder Kids visit is a nurse-led visit with developmental assessments and teaching. Every visit includes an inventory of social determinants of health. The physician joins for the first month and at routine well checks, and the social worker meets with the families at many visits. Integrated behavioral health specialist meets with families at least twice the first year, and pediatric OT meets with all families at 1 month and 6 months. Gunder Kids encourages the use of this medical home. The nurse carries a direct line phone, and parents are encouraged to call with questions. Some of the lessons learned that Dr. Budzak shared with me is that it's all about building relationships with these families. It's critical to treat patients with respect and be non-judgmental, and to understand most of the parents have a history of trauma, and they have a strong desire to be good parents, and that addiction is a chronic disease. So the Wisconsin Association for Perinatal Care is where individuals and organizations can come together to improve perinatal care and outcomes. So I want to show you this website, and I've talked to the people on this website. All of the educational material on this Wisconsin website can be printed and used, and I'm going to see if I can open this just to show you. Are you able to see this screen or no, Elizabeth? Might have opened it on the wrong side.
No, it's still your slides.
Okay, let me try again. Still no?
No.
Oh, I'm sorry. So I don't know. Let me try that. Now are you seeing my slide in like pieces?
Yep, now it's in the PowerPoint. And we can see all your slides.
Okay. I'm going to see if I can open this. Open hyperlink.
Yep, we can see it.
You can see it now?
Yes.
Okay, so I just wanted to show you this website. And if you go to major initiatives and then perinatal substance abuse and then resources, you can print any of this stuff out. So I told you about the medication chart that talks about the drugs that we talked about that can be used for medication-assisted treatment are all here. And as well as medications that can be used to treat infants and what the effects of these medications are, risks for mom and baby. There's also lots of different educational opportunities. And for those of you home visitors and social workers, there's assessment and intervention in the home for women and infants affected by opiates, which I think is really helpful. So it just kind of puts this talk into a short version here about neonatal abstinence syndrome, the medications again, the length of withdrawal, the symptoms for infants, breastfeeding, and interventions for infants with neonatal abstinence syndrome that really include decreasing the stimuli. These kids' neurological system is already overstimulated. So talking softly, dark rooms, providing a quiet, calming environment, making sure that the infant has something to suck on, and helping mom respond to their cues. There's also a handout that you can give right to the moms. So I do encourage you, if this population is somebody that you deal with often, to look at this website. This Newborn Withdrawal Project and Educational Toolkit has a handout for moms that are addicted to opioids during their pregnancy to try to help them understand what is going on in their body, the importance of medication-assisted treatment, as well as a handout to help them understand neonatal abstinence syndrome and how to care for their infant. Okay, from current slide. Okay, Elizabeth, am I back to slide?
Yep, you're good to go.
Okay. So some additional considerations for our multidisciplinary team as we strive to provide better services for women and their families who are affected by substance abuse is what public policy should be implemented to reduce the use of alcohol and drugs by pregnant women and to protect children? What services can be provided to pregnant women? What services and protocols do we need during labor and delivery? What are the protocols for responding to referrals made by hospitals on substance-exposed infants? And postpartum, how are these cases screened by child protection? How is progress in treatment monitored? And how are decisions on reunification or case closure made? Some key points are the health and safety outcomes for women with addiction and their exposed infants can be drastically improved with medical care, prenatal care, pediatric care. Also, they can be improved by encouraging and assisting mothers into drug treatment and mental health treatment and helping them with their basic needs like housing, nutrition, making sure that they're safe and not victims of domestic violence, providing parenting education and home visitation programs, and to help them prevent future unwanted pregnancies or additional infants exposed to drugs in utero. These are some of the statutes and policies regarding substance abuse in pregnancy. This is a list that govern the intervention in cases of unborn child abuse and substance-exposed and alcohol-exposed infants. Please work with your agency supervisor and attorney for guidance in intervening under these statutes. CAPTA requires states to have policies and procedures to address the needs of infants born and identified as affected by illegal substance abuse, withdrawal, or symptoms of fetal alcohol syndrome. These are my references. And thank you so much for attending. I'm going to put this slide up to report your attendance for the live webinar, and then I will also stay on the line for questions for the next 10 minutes.
We do have a couple questions. One, if Suboxone is contraindicated, why are there so many women who are prescribed it? Are there other competing outcomes which make it reasonable to prescribe?
Subutex, remember Suboxone is a combination of buprenorphine and naloxone. That's contraindicated during pregnancy because we don't want the baby to go in withdrawal if this mom decides to inject it, which will put her and her baby in withdrawal. So a non-pregnant woman could definitely be prescribed Suboxone. Subutex is buprenorphine without the naloxone, and that's what's given to pregnant women. So if somebody's saying it's Suboxone, it probably isn't. It's probably the Subutex because providers would know that Suboxone, the naloxone in the Narcan in Suboxone is contraindicated. Suboxone or Subutex is being prescribed more than methadone now because it is associated with shorter hospital stays and less neonatal abstinence syndrome. So I hope that was clear. But again, Suboxone and Subutex are not the same thing. They both contain buprenorphine, and that's the medication that stops the withdrawal. Suboxone, they add Narcan to it, so if the person injects it, they go into withdrawal. So it's trying to help so the person doesn't try to abuse their prescribed medication used to treat their opioid addiction. Is that clear?
Yep, thank you. And for newborns, is there much variation between CordStat, MEC, or urine testing? I see at the hospital we do CordStats versus MEC, but curious if one does better with time frame and results over the other.
I see a lot of variation too. I think it depends on how you want to use the information. You know, if you're working with a mom that said she stopped using a couple months ago, then a positive meconium could be consistent with that history by the mom. If you want to know if she's still using, then the cord blood or the urine would show more recent use.
Okay, that's all the questions we have at the moment. Thank you. And Jennifer, I'll ask that you make me presenter so I can share the attendance slide after you leave. Attendees, if you have not already done so, you may now text the attendance code and complete your evaluation. Please join us for next month's webinar using the Child Protector app presented by Jim Anderst and Angela Rabbit. Thank you for being with us today.
And Elizabeth, can you tell me how I make you the presenter again?
Yep, you'll want to expand the control panel. So the orange arrow on the corner of your screen. And then right click me.
Got it?
Yep.
Okay.